Hello students, welcome you all to the session of Sparks, in which today we are going to see about the important topic about antepartum hemorrhage, which is very important regarding how we can able to found the diagnosis of the patient presentation and the complaints of how they are asking the questions. So this is a very important topic we have to know in a view of obstetrics and gynecology. Now speaking about the first thing, antepartum hemorrhage. First you have to know at least about the definition, right? So saying about the definition, hold on. Yeah, it is a blood loss from the genital tract. So how long it will be a blood loss? Yes, hold on. Yes, so blood loss from the genital tract after a period of viability of, you can able to see 28 weeks. So this is very important. Blood loss if a patient is a pregnant and after 28 weeks she is following a blood loss, she is having a complaint of bleeding, then it comes under antepartum hemorrhage. So please remember, so bleeding per vaginum before delivery of the fetus, before delivery of the fetus, or you can say after the age of viability. So what is the age of viability? Here we are saying that it is 28 weeks. So that is important, 28 weeks. Now our WHO is saying that 22 weeks is the age of viability. Very important, please remember. So that is very important. So if you see in APH, what is in APH? In antepartum hemorrhage we have two things. Either if it is a patient complaining in the 28 weeks, after a 28 weeks about a complaint of bleeding, then either one cause, it might be a placental abruption, okay? Either it might be a placental abruption, or one more cause, that will be your placenta previa. Please be clear about these terms, okay? Placenta previa. So what about these two things? First we'll be seeing about placental abruption, premature separation of placenta. So what is placenta abruption? Premature separation of placenta. This shows about your placental abruption, right? So seeing next, abruptio placenta, placental abruption, both are same. So we have seen that it is a premature separation during the age of viability after 28 weeks. In WHO says which is a 22 weeks. So what are all the risk factors included in that? For example, if the mother who is having either hypertension, she might lead to preeclampsia, right? Preeclampsia, she might be the risk factor for this kind of abruption placenta. And one more risk factor is the age, her age, and another risk factor, her parity, how many pregnancies she had before, parity. The another risk factor is smoking, right? If the mother is a smoker, then that is also an risk factor. Again, if she is having a abdominal trauma. So these are all the very important reason for placental abruption. So the main risk factor for placental abruption is previous LSCS. So lower side of the cesarean section is a very important risk factor for our abruption. So please remember this, and this is also an important clue. Now, why most common cause of DIC is placental abruption? See, the risk factor we have been spoken about. If we are speaking about the most common cause of DIC, that is disseminated intravascular coagulation, is your placental abruption. Why? The reason is, for example, there is a type called as a concealed abruption. In that you can get this type of disseminated intravascular coagulation. We are going to see why. Before that, please remember what are all the types. The types will be concealed abruption, revealed abruption, and one more type is your mixed abruption. They can ask you a question, most common type of abruption is your mixed abruption. Which is the most dangerous? Dangerous is your concealed abruption. Clear? Dangerous is your concealed abruption. So very important to see what is very dangerous and what is most common. Okay. So some more other important risk factors are, you can see. So this is your placental abruption. So this is your normal placenta. You can able to see here, right? So can you able to see, this is the normal placenta, and here you can able to see the hemorrhage because of any of the reasons. The risk factor which we have seen before, that is your age of viability or more paras, the age of a mother could be more, or she might be in a case of a smoker or alcoholist. One more important risk factor which we have to remember at least is your thrombophilia. The mother might be a case of thrombophilia, or she might be having a polyhydramnios, right? Or else she is having a retroplacental clot even before. Retroplacental clot. So that is also important. So can you able to see some hemorrhage over here, right? So same like that, in this next picture you can see the concealed hemorrhages. Sometimes the hemorrhage may be revealing out, that is your revealed hemorrhage. Sometimes it must be inside your uterus forming a clot, that is concealed hemorrhage. As this is forming a clot inside, making a concealed hemorrhage, this might be the reason of our DIC, disseminated intravascular coagulation. Now see, this is a picture of a covalent uterus. Covalent uterus. Why? Because of this type of a concealed abruption, you can able to see the covalent uterus. What happens in the concealed abruption? If you see, the lower end is not, lower edge of placenta is not separated. If placenta is separated from the uterus endometrium, then that will be your revealed abruption. Now the lower edge of placenta is not separated. Clear? So that will be your covalent uterus, where you can see the whole over hemorrhage inside your uterus, the whole hemorrhage along with the fetus inside the uterus. So that is important. Again, what are all the clinical features you can see? The patient will be complaining of an abdominal pain, especially she is giving some history. Either she is having a pain over since last 1 week, or she can give a history of she cannot feel the movement of the fetus. She might be giving some antecedent history, some cause might be there with the abdominal pain. Yes, along with that you can see what is the one more clinical feature. There will be dark bleeding. Okay, so this is also important. So what happens in perabdominal examination? The physician can see the uterus which feels very tender. The uterus feels very tender and it will be contracted in manner. That is also important. Sometimes the patient along with the dark bleeding can lead to followed by shock. So please remember this picture where it shows the covalent uterus. This picture have been already asked in the exams, and there is a many opportunity that it can be asked again in the exam. So abdominal examination, there is a tenderness in the uterus and the uterus is contracted as well. So for example, whenever we are doing abdominal examination, the gynecologists will say either the fundal height is equal to the fundal height which they check per abdomen will be equal to their period of gestation, how many months they are saying as a last menstrual period. So when seeing here, the fundal height will be very high, very more regarding her POG. What is POG? This is the period of gestation. That will be very less comparing to their fundal height. That is important. So this is the covalent uterus where you can see the whole bleeding over here. So you can see the whole bleeding and there is a clot formation regarding the hemorrhage. If you see, the bleeding will be going from myometrium to the serosa. That is very important. You can able to see the bleeding which was from the myometrium to the serosa, which makes the concealed part of a hemorrhage, which shows like this covalent uterus. So how can you manage the patient? For example, if you say or if you feel that the patient's fetal heart rate is present, then how would you manage the patient? or such if the fetal distress is there, means you are not feeling the fetal heart rate, or else if you are not feeling the fetal movements properly, then what would be your management? That is what they are asking. See, basically in the fetal heart rate and fetal distress, regarding this, the resuscitation is very important. How we are going to manage this kind of a patient with abruption of placenta? For example, fetal heart rate is present, you can able to augment the labor. Okay, easily you can do normal vaginal delivery. For example, if there is a fetal distress, then what you will do? You will go for cesarean section. So how would you decide? For example, you can feel everything and everything is normal, like fetal heart rate, fetal movements are palpable, then easily you can augment the labor with the normal vaginal delivery. Or if fetal distress is there, you can go with the C-section. In case there is DIC, there is a clot formation, there is a disseminated intravascular coagulation, then how would you manage the patient? You have to treat this DIC by FFP. You have to treat the patient by fresh frozen plasma. Then you have to augment the delivery by normal vaginal delivery. So this is very, very important, how we are going to manage the patient. Right. So investigation, like, can you able to see this? Placental abruption is a condition where there is no role of USG. Why? Because in ultrasound you can able to localize the placenta, but you cannot able to see what is exactly happening over inside. These placental abruption, please remember, these are a kind of a condition where you can find it only by your clinical diagnosis. There is no role of USG. When you can be using USG, either you have to rule out the localization of placenta, especially the low-lying placenta in which leads to placenta previa. Sometimes you can able to rule out the placenta previa by this kind of USG until and unless you are not able to use this ultrasound for diagnosing the placental abruption if you are not going to see clinically. Right. So what is Paget's classification? So if you are able to see, this is a Paget's classification which says severity of placental abruption. So they can ask you a question, which classification of placental abruption have been mentioned over here? That's a Paget's classification. Okay, that is important. So now we have seen concealed abruption. Now speaking about the revealed abruption, already we know that from the uterus the bleeding is about to come out. In the concealed it will not be coming out. In revealed abruption you can easily see that lower edge of the placenta is separated. Can you able to see here? Lower edge is separated, but in concealed it is not separated. This is important. Clear? So there will be bleeding, but how is the consistency and the bleeding can be shown? This is a kind of a dark red. The bleeding will be dark red with some history of cause. The patient will be complaining this kind of bleeding with some history, either whatever the thing is. Either she might be having some trauma, some accidents or whatever the cause, but she will be complaining some cause for this kind of a bleeding, but pain will be less comparing to the concealed. Pain is less. That is important. Here if you see, the fundal height which we are going to see is equal to your period of gestation. If the last menstrual period gestational age is calculated, the both will be equal. Please remember, what we have seen in the concealed abruption, it will be higher. In revealed abruption, it will be equal. This is also one of the question which can be asked. Right. Now there is a question which I want you people to read and answer. A multigravida 33 years old. Please always when you are reading the question, note down and pick up the points wherever you can see the clues. Okay. So 33 years old and 35 weeks of gestation with previous history of LSCS along with DNC done once in a while. She came with a complaint of bleeding. Fetal heart rate is normal. So remember here, fetal heart rate is normal. Per abdomen shows relaxed uterus. So per abdominal examination is showing some relaxed kind of a uterus. Now transvaginal ultrasound shows low-lying localization of a placenta. They have been mentioning what is the next step. So can you see the options like immediate termination of pregnancy, option A. Option B, admit the patient, monitor and start the steroids. And option C, active management. Along with the option D, there is C-section which is recommended. So what you will be your answer? What will be your next step we are going to do for this patient? See, the patient is 33 years old, 35 weeks she is in a gestational period of, and she is having a previous history of LSCS, and also DNC have been done once, but the uterus is relaxed. Please remember, in your placental abruption, just now we have seen, what we have seen, your uterus will be contracted just because there is a concealed hemorrhage or bleeding. So for sure there is no option that it will not be a placental abruption, right? So, and you can see fetal heart rate is normal. Very rare in the placental abruption you can see fetal heart rate should be normal. In placental abruption you cannot feel the fetal movements palpable easily, that is not palpable easily, and fetal heart rate will not be normal at any cause in your placental abruption. So now if you are able to see immediate termination of pregnancy, you can do? No. You can admit the patient or monitor? It's not possible. So active management, what do you think? Yes, this is a question of placenta previa, and how you're going to see this question, I'll be giving you the clue. See, this is the normal placenta. You can able to see here, this is the normal placenta, and if you see, the placenta is somewhat marginal to your os. This is your internal os, and the placenta is somewhat marginal to that. And you see the next part of a partial placenta, literally it is touching the internal os. And what is total placenta previa? It was totally covering the os. So these are types of placenta previa where their localization gives a type, totally covering the os. So what does placenta previa mean? It actually means low-lying placenta within 2 cm to the os, within 2 cm to the internal os. So this is the opening which is below, it is your internal os. That is important. And mainly the patient will be giving a history of LSCS. Okay, cesarean section they will be giving history, and some other time your age, your parity is also sometimes will be a risk factor, but most probably LSC is your risk factor. Now coming to this, sometimes even placental abruption goes along with the risk factor, so that is why we have to read the whole question along with it, so solve easily. Now coming to the next part, there is a de Browne classification in your placenta previa, that is first part, second, third, and your 4 classification of de Browne. What does it says? It says something like the placenta will be lateral, that is within 2 cm, within 2 cm. Sometimes it is marginal, which we have seen in the picture now, that is up to the os, up to the os. And the third one, in which internal os is closed, internal os is closed, but it is near to your internal os, covering them, it is near. And fourth, totally covering the os. So this is your de Browne classification of placenta previa, which you have to remember. In the marginal placenta, especially in the posterior covering, you can see a sign called as a Stallworthy sign. Stallworthy sign. What happens? Because of this compression of placenta decreases your fetal heart rate. This can decrease your fetal heart rate. So that is called as a Stallworthy sign. Clear? Now seeing about the clinical feature, what you can able to see? You can see bleeding, obviously. Bleeding will be there, but there will be a painless bleeding. painless bleeding, and there is no any cause easily. There will be a painless bleeding and causeless will be there. The patient will not be saying any history at all, just simply they will be giving a complaint of bleeding. So that is what one of the important thing. And usually the fundal height when you are checking by per abdomen will be equal to your period of gestation. That is also important. So if you see in per abdomen, what you can able to see, you can see a soft relaxed uterus, and you can feel the fetal heart rate easily. Fetal heart rate is felt easily, and fetal movements, FM fetal movements are easily palpable. Easily palpable. At what condition fetal heart rate can decrease? It can decrease in the Stalworthy sign, where the compression of placenta will be there. So how can you investigate this kind of a patient? By transvaginal sonography also, by transabdominal sonography also, but which is most very nice and the most common to be going through in, that will be your transvaginal sonography. The first importance and the most useful investigation for this kind of a placenta previa is transvaginal sonography. Now, if you can able to see in your per vaginal examination, PV means per vaginal examination, it is contraindicated. Question: why it is contraindicated? Why? Because when you are going to do per vaginal examination, for example, if you are giving the fingers to for doing per vaginal examination, you can able to interrupt the placenta, you can make the placenta to bleed more. So that is why per vaginal examination is contraindicated in placenta previa. Please remember, placenta previa. Now, what is the management of them? You can manage by both conservative way and in the active way. That depends upon the patient's stability. For example, if the patient is less than 37 weeks, or else sometimes if the patient is hemodynamically stable, for example, she is not having any other kind of features within her, she is perfectly conscious and stable within her limits by the way of clinically, then sometimes if suppose she is able to admit and we can monitor the patient, it is easy for us to do as a conservative management, and there is no active bleeding, then there is active bleeding but still she feels a pain, we can follow a role of a protocol which is called as a McAfee protocol, in which we admit the patient, monitor the patient, investigate by all the blood levels and all blood investigations, and then we have to give steroids. Why? As such they are less than 37 weeks, we have to see the fetal lung maturity. We have to see the fetal lung maturity, so that we are giving steroids for the fetal lung maturity as they are less than 37 weeks. So what is the active or immediate management? Go with cesarean section. When you can go with cesarean section? Either if it is more than 37 weeks with some fetal anomalies. With some fetal anomalies, you can go with cesarean section. Or else, if suppose less than 37 weeks but hemodynamically unstable, then you can go with cesarean section. So if it is more than 37 weeks but also having fetal anomalies, if it is less than 37 weeks with hemodynamically unstable conditions, you can go with the cesarean section management. So this is a management which you have to give at least for a patient regarding whether conservative or the immediate active management. So you can see the question again. See, she is having a complaint of bleeding and DNC before, and previous history of LSC is relaxed uterus. These are all the clues which shows we cannot do immediate termination of pregnancy as she is 35 weeks with no fetal anomalies. So we can go with the option of admit the patient, monitor the patient, do all the blood investigations and start the steroids so that fetal lung maturity will be gaining fine. So we cannot do active management as such, the patient is less than 35 weeks, and we cannot go for cesarean section also, right? So the next question which we are going to see is, there is a primigravida is in labor for 12 hours. See, 12 hours. with tender and rigid uterus. Rigid uterus very difficult to palpable, and you can feel the tone of the uterus easily while per abdomen investigation. So fetal head is not palpable, means fetal parts are not palpable easily. So fetal movements are also not seen. So loss of fetal movements per abdomen. So what is the most probable or the appropriate diagnosis? PROM, first option, premature rupture of membranes, placenta previa, placental abruption, polyhydramnios. So you can able to see this and you can see what is the diagnosis. See, 12 hours, rigid uterus and loss of fetal movements. It obviously goes with placental abruption. Why? There is a bleeding. There is a complaint of a primigravida in labor. That is a clue. Fetal heart rate and the fetal movements FM is not palpable, but in placenta previa it is easily palpable. This one itself shows a good difference between ruling out placenta previa along with the placental abruption. So one more clue is a rigid uterus. It is a main investigation per abdominal investigation. You can see the rigid contracted uterus along with the relaxed uterus which is in placenta previa. So how can you manage the both? If placental abruption, easy. Either you have to see whether the fetal heart rate is normal, then you can go with a normal vaginal delivery, NVD, normal vaginal delivery. If there is a fetal distress, go with cesarean section. Go with cesarean section. As such, they have mentioned some fetal distress showing loss of fetal movement. So here the treatment would be go with cesarean section, and they haven't given any signs of disseminated intravascular coagulation, DIC. There is no use or no need of FFP transfusion in the treatment. So in placenta previa, what you will do? In placenta previa, if you have been fine, there is a no painless bleeding. These are all the clues. Painless bleeding, and there is no cause for the bleeding. Literally the patient will say the painless bleeding. And again, sometimes the fetal heart rate will be palpable. Fetal movements are also good, but there is a placenta previa. What is the management? We are dividing by the McAfee protocol. Just now we have seen either less than 37 weeks or more than 37 weeks. If less than 37 weeks, also two conditions you can terminate the pregnancy by cesarean section. One is your fetal anomaly. Or the patient is hemodynamically unstable. So these are the two things how we can able to manage the patient with either placenta previa or abruptio placenta. So these are the main points and the clues which able to differentiate between the both kind of a antepartum hemorrhage which comes after 28 weeks of the age of viability before the delivery of fetus. If after the delivery of fetus, then it is called as postpartum hemorrhage. We'll be seeing that in our next video, in the next session. Like these, we'll be discussing many kinds of questions as well in our next further sessions. So any kind of doubt or any kind of issues, you can be asking question in the Telegram group as before. So thank you.